So again, welcome. A couple of housekeeping items as we get things rolling here tonight. All attendees are in listen-only mode. We will not be able to answer any questions related to your specific condition. Be sure to type your questions in the Q&A box so we can answer them at the end of the presentation. I'll be keeping my eyes on that. And just so you know, this webinar is being recorded and will be available on the Mended Hearts website at www.mendedhearts.org and on our YouTube channel. I'd like to welcome our speaker tonight. Please join me in welcoming Dr. Jeremy Van't Hoff. He's a cardiologist and assistant professor at the University of Minnesota. His clinical interests include early detection of cardiovascular disease to prevent or delay the onset of cardiovascular events. He also specializes in familial hypercholesterolemia, resistant hypertension, and complex polyvascular disease. He believes in an integrative treatment approach combining lifestyle alterations with evidence-based medical therapy to maximize physical and mental health as well as quality of life. His research focuses on cardiovascular disease prevention, early detection, and health disparities. His scholarly works spans epidemiologic studies of risk factors and preventative behaviors, things like aspirin use and blood pressure control across populations. Social determinants of cardiovascular health, including neighborhood and community influences, and improving screening and intervention strategies to bridge gaps between public health and precision medicine. He also leads projects on hypertension control, left atrial function, and clinical interventions aimed at mitigating progression of heart disease. Before we begin, I would like to thank our sponsor. We are grateful to AstraZeneca for their support in making this webinar possible. And be sure to, again, to put your questions in the Q&A at the end of this presentation. All right, Dr. Van't Hoff, I'll pass it off to you. I will stop sharing and I will let you go from here.
All right. Well, thank you very much, Karen, and thank you for everyone who has logged on to attend this talk tonight. I look forward to spending the next 40 minutes or so talking about hypertension and what we can do to diagnose and treat it. Okay, so a couple of disclosures. I receive research grant funding from both the American Heart Association and the NIH. All right, so a little outline of what we're going to cover today. So we'll start by defining what hypertension is. We'll understand why blood pressure is important, why we should all care about it. We'll learn about risk factors for hypertension. We'll discuss how to measure blood pressure accurately. And then we'll learn how to lower blood pressure both through lifestyle modifications and medication use. And then lastly, we'll understand why sometimes it can be difficult to control hypertension. So let's begin by defining hypertension. So when the heart beats, it pumps blood into your blood vessels. And this causes pressure against the vessel wall. And this is what causes blood to move downstream to the tissues and organs that need blood and oxygen. Hypertension is the medical term for high blood pressure. So when the pressure inside the vessels gets too high. And what that means is that this high pressure, can cause damage to the blood vessels themselves and to the organs that are downstream. Now, why does it matter that blood pressure is high? Two main reasons and one is that high blood pressure is the most common cardiovascular disease risk factor. And two is that it's modifiable. So it's something that we actually have control over and can alter to improve cardiovascular disease. And here you see listed several of the cardiovascular conditions from heart health to brain health to kidney health that are all impacted by high blood pressure. So starting with the fact that hypertension is very common. So almost half of American adults have high blood pressure. And as you can see from this slide, the likelihood of having hypertension increases as one ages, so that once you're above the age of 55, over two-thirds of adults have high blood pressure or hypertension. In this slide, we see hypertension prevalence, or the percent of people who have hypertension in different races and ethnicities. And in the middle of the slide, you see that non-Hispanic Black males and non-Hispanic Black females are the most likely to be diagnosed with high blood pressure. The color of the bars indicates different time periods. And what this shows us is that the hypertension prevalence has not really changed very much over the past 20 years. Hypertension remains very common. Because it's so common, hypertension is the leading risk factor for chronic disease risk, for chronic disease. So not just blood and vascular and heart disease. This is all chronic diseases. High blood pressure is more impactful than cigarette smoking, pollution, diet, alcohol use, etc. When you consider cardiovascular disease alone, hypertension is again the most impactful risk factor, more impactful than high cholesterol, more impactful than weight, more impactful than glucose. And it's a more problematic than in any of the behavioral risks or the environmental risks. But the problem with hypertension is that it often has no symptoms. So a person might be going along with their normal life and not feel anything while still having elevated blood pressures. And that leads to a problem with control. So many people with high blood pressure are aware that they have high blood pressure. So about two-thirds of people know that they have high blood pressure. A little over half of them receive treatment, so maybe an area for improvement here. But only about 1 in 4 people who are diagnosed with hypertension actually have their blood pressure under control. And we'll get back to the reasons for this in a little bit. Okay, so let's move to hypertension risk factors. So here's a list of risk factors for high blood pressure that are difficult or even impossible to control. So first, family history or genetics plays a big role for developing high blood pressure. As we saw before, race ethnicity impacts hypertension diagnosis, aging impacts hypertension, chronic diseases like sleep apnea and chronic kidney disease increase risk for hypertension. And then chronic psychosocial stressors can raise blood pressure, and even air pollution can raise blood pressure. Now, many of these things are out of our control, but there are many factors that we can control. So here's a list of factors that could be modifiable. So unhealthy diets, especially those high in sodium, can cause increased blood pressure. A lower intake of potassium or calcium can cause high blood pressure. In some people, consuming black licorice can increase blood pressure. Many common medications that people use, like pain medications like ibuprofen, can increase blood pressure. Antidepressants, some decongestion medications can all raise blood pressure. And then there are health factors like increased weight can increase blood pressure, lower physical activity, alcohol or nicotine use raises blood pressure, and then stimulant drug use also can raise blood pressure. Well, what is hypertension? So we've talked about risk factors, we've talked about why it's important, but what exactly are we talking about when we're talking about hypertension? So this is a figure straight from the most recent hypertension guidelines, which were published within the last year. And what you see is that normal blood pressure is defined as a systolic blood pressure less than 120 and a diastolic blood pressure less than 80. So this is the top number, 120, and the bottom number, 80. There's an in-between range of 120 to 129 over less than 80 that is considered elevated. And then stage 1 hypertension diagnosis comes in when the top number is between 130 and 139, and the bottom number is between 80 and 89. Stage 2 hypertension is when that top number is over 140 or the bottom number is over 90. So you have normal, elevated, stage 1, and stage 2 hypertension. So what do these two numbers mean, the systolic blood pressure and the diastolic blood pressure? So the systolic blood pressure is the top number, and that's the one that we focus on the most usually when we talk about diagnosing hypertension and controlling hypertension. So this is the pressure in the arteries when the heart beats. So the heart contracts, pushes blood out of the heart into the blood vessels, and it causes a rapid increase in blood pressure, and we measure the peak, and that's the systolic blood pressure. The bottom number is the diastolic blood pressure. So this is the pressure in the arteries when the heart relaxes between beats. Well, how do you accurately measure blood pressure? In order to have these numbers, you have to measure it, right? And so this is a figure from the American Heart Association that discusses the appropriate steps to measuring blood pressure. So you begin with avoiding some of those things that we discussed as risk factors. So don't smoke, don't exercise, don't drink caffeinated beverages or alcohol within 30 minutes of measurement, because all of those things could cause an increase. Then it says you must rest in a chair for at least 5 minutes with your arms supported and your feet flat on the floor. After 5 minutes of sitting calmly, you put the blood pressure cuff at the bend, or sorry, just above the bend of the elbow, and make sure that you use a device that is calibrated and validated. And over here, I listed a couple of websites that have validated blood pressure cuffs that are commercially available, validatebp.org and stridebp.org. And as a reminder, cuffless monitors, although very interesting and popular right now, are not recommended for monitoring blood pressure and diagnosing hypertension. And then, so once you have the cuff on, then the recommendation is to take two readings about 1 minute apart. And this says in the morning before medications or in the evening before dinner. This will depend on what your clinician requests and how they might be monitoring your blood pressures. So these are recommendations for how to check blood pressure at home. This is for anyone who is interested in following their blood pressure over time. But all of these techniques ideally would be used in the clinic as well. Now, we all know that clinics are kind of hectic places and can be very busy. And so the likelihood of someone sitting quietly for 5 minutes in a quiet room to check their blood pressure is uncommon. Hopefully that can be done. But if it's not, um, I think this just emphasizes how important it is to get accurate blood pressures outside of the office, at home, where people live 99% of their lives. Okay, some patients like to know, well, when should I call in when your blood pressure is too high? So you're checking your blood pressure at home. What should you do with a high number? So we talked about stage 1, stage 2 hypertension, but there are a couple of categories beyond stage 2, severe hypertension and hypertensive emergency. So severe hypertension is defined when the top number is above 180 or the bottom number is above 120. If you have those numbers but no symptoms, that's called severe hypertension, and it's recommended that you call your physician team or your clinician team. If you do have symptoms, and typical symptoms that we see in very high blood pressures are things like chest pain, shortness of breath, back pain, numbness, weakness, or changes in vision or difficulty speaking. This is now a hypertensive emergency. So this is a call to 911. So blood pressure above 180 over 120 with any of these concerning symptoms, that the recommendation is to call 911. That's hypertensive emergency. So then the opposite question is, well, can blood pressure be too low? Too low? And yes, of course, it can be too low. And here are some symptoms of low blood pressure: confusion, dizziness, nausea, fainting, fatigue, neck or back pain, headache, blurred vision, palpitations. So these are non-specific symptoms and can be caused by many things. But when it's related to blood pressure, typically we see systolic blood pressure is less than 90 millimeters of mercury. Now, they, I have seen patients, and there are certainly circumstances where someone is used to and has lived at a much higher blood pressure for a duration of time. And so even with normal, quote unquote, normal range blood pressures, if they drop from a high blood pressure to a normal range, they might feel some of these symptoms. And we'll discuss that a little bit more later as well. Okay, so now that you've measured your blood pressure and you've found that it's high at home, what do you do next? So this is an illustration from the guidelines. And what I want to point out is that lifestyle modifications are at the foundation of any intervention for hypertension. The question comes in where you question, should you start with lifestyle and wait to start medications, or do you need to start medications right away? And we'll go into a little more detail about how your care team might decide whether or not to start medications. But let's begin with my lifestyle modifications. So lifestyle modifications are very effective at lowering blood pressure. And I've listed out several here, and we'll go through them one by one. So weight loss can lower blood pressure, and you might expect about 1 millimeter mercury reduction in blood pressure for every 1 kilogram, or a little over 2 pounds, reduction in body weight, up to 6 to 8 points reduction in the systolic blood pressure. So pretty powerful. Eating a heart healthy diet, so DASH diet specifically, has been designed to lower blood pressure. And in general, this is a diet that is rich in fruits and vegetables, whole grains, and low fat proteins and dairy products. You can expect about a 5 to 8 millimeter of mercury reduction in systolic blood pressure. By reducing your sodium intake, with an optimal goal of less than 1,500 milligrams per day, you can lower blood pressure by 6 to 8 millimeters of mercury. Instead of sodium chloride in your typical salt shaker, you can use a salt substitute that uses potassium chloride to lower blood pressure 5 to 7 points. You can also just increase your potassium intake to lower blood pressure by about 6 points on average. And reducing alcohol can lower blood pressure by 4 to 6 millimeters of mercury. The guidelines state that the optimal goal for lowering blood pressure is no alcohol, but in those who consume alcohol, about a 50% reduction can give you changes in the 5 millimeter mercury range. So this is kind of a focus on what you can change in terms of consumption. Well, what can you change in terms of activity? So exercise lowers blood pressure, and I think the good thing here to report is that it doesn't matter what type of exercise you do. Any sort of exercise can lower blood pressure. So aerobic exercises, walking, jogging, etc., with the goal of about 90 to 150 minutes per week, can lower blood pressure by 4 to 8 points. Dynamic resistance, so this is weightlifting, can also lower blood pressure quite effectively. And then isometric resistance. So the example that they put in the guidelines is hand grip. This would be like anything that flexes muscles and holds. So planks would be another example. So any type of this exercise can lower blood pressure. They also talk about a meditation, and this is specific meditation with a professional guide can lower blood pressure. And then breathing control. So certain breathing exercises can also lower blood pressure by 5 points. So many different options for lifestyle modifications that can have quite an impact on blood pressure. Now, this is a little bit of a complicated slide, but I'll go into it in a little more detail. So this is from the guidelines, and this talks about when to recommend starting medications at the time of diagnosis. So with everyone, with all patients, the recommendation is going to be work on lifestyle, optimizing lifestyle and cardiovascular health factors. But when might you say, I think we should really start medications right away? So focusing here at the bottom, when the blood pressure is in that stage 1 zone, so this is 130 to 139, here you can this is where you can have people start with some lifestyle interventions and recheck blood pressure in about 3 to 6 months. If after that time frame, blood pressure is still elevated, that's when you start talking about adding medications. Next box up, this talks about your if your care team thinks that your cardiovascular disease risk is elevated, and specifically they talk about this prevent calculator and having a risk over 7.5% per in 10 years. Those are details that you don't need to worry about specifically, but the point is, if your team thinks that you're at higher risk for cardiovascular disease, the guidelines say you should start medications right away. And then moving up, there are certain diagnoses where the guidelines recommend starting blood pressure medications right away. So if you have a diagnosis of diabetes or chronic kidney disease, or you already have cardiovascular disease like heart disease, stroke, or heart failure, then the guidelines recommend starting blood pressures at the time of diagnosis of high blood pressure. Now, again, what I tell people in some of these categories is we can start medications. You definitely can identify ways to modify your lifestyle to lower blood pressure, but medications will work within a couple of days, right? But you can still have a few months to work on lifestyle. If you continue to lower blood pressure, when you come back, we can check and see maybe now your blood pressure is even lower under better control and you can come off the medications. So I don't think that not you're not necessarily stuck on these forever if there are some lifestyle modifications to work on. And then going to the stage 2 hypertension, so this is when you're above 140/90. There again, the guidelines recommend blood pressure medications at the time of diagnosis in addition to lifestyle. And in fact, the guidelines recommend starting two different antihypertensive or blood pressure medications at the same time. I'll be honest, this is something that I don't typically do. And the reason is because, as we'll talk about in the next slide, or next couple of slides, there are many side effects to blood pressure medications. And when you start two at the same time, it's sometimes difficult to know which one is causing which symptom. But if you hear from your physician that they would like to start two medications, this is why. Okay, moving on to the medications that are available. So there are four classes or families of medications that are recommended for the initial therapy for lowering blood pressure. And those families are thiazide type diuretics, ACE inhibitors, angiotensin receptor blockers or ARBs, and calcium channel blockers. And within these four different groups, there are many options, as you can see. So if one medication doesn't work or there are side effects from a certain medication, there are many choices. If you've tried if you tried all of these families and for whatever reason blood pressure is still not controlled, there are many other options available. 31 different medications in about 14 different families of medications, including other channel blockers, different types of diuretic medications, beta blocker medications, alpha blocker medications, etc. The point I think that I'd like to make with this is there are a lot of options for your team to lower blood pressure. And so if something isn't working, don't be discouraged. There are other options. And and you should let your team know if it's not working. Okay, if we have so many options, then why, again, are we having such a difficult time controlling blood pressure? So you may have heard that hypertension has been called the silent killer. And I think here's a little illustration to show why that might be. So here we have a person with a high blood pressure, quite high, but feels asymptomatic again. So feeling well, blood pressure is high, never knew it until they measured it. They come in, we start them on some great medications. We have a lot of options. Maybe they start two or three. We get to an excellent blood pressure, very well controlled, but the patient feels crummy. So you take someone who feels great with a high number, you make them take several medications every day, and now they feel crummy. What's going to happen? Well, it's very likely that they'll consider stopping those medications that make them feel poorly. So why do people feel bad? So let's go over a few of the common side effects from hypertension medications. So these again are the four classes of medications that are first line therapy. So starting with thiazide diuretics. One of the side effects is increased urination. Well, in fact, that's one of the reasons or the ways it lowers blood pressure. It causes you to create more urine, and sometimes you can lose electrolytes in the urine and cause some low values in your blood. You can feel fatigue from diuretics. You might feel dizzy if blood pressure gets too low, or you get dehydrated. So there's shifts in blood pressure when you stand up. Um, there's a small percentage of the population who can get a chronic cough from ACE inhibitors. They can cause elevated potassium. And in a small amount of people, you can have an allergic reaction that causes swelling and or a rash. The angiotensin receptor blockers are actually one of the best tolerated classes of medication. And the most common side effect is elevated potassium. And then lastly, calcium channel blockers. They can cause swelling, especially in the legs. Sometimes they can cause headaches, and they can cause flushing. So here's a list of side effects that might make it undesirable for someone to take these medications. And I think it's worth pointing out and understanding and having this conversation between the patient and the provider. In addition to side effects to medications, there are several other challenges that can make it difficult to control blood pressure. So the first is the fact that as you increase the number of doses per day, medication adherence goes down. So when at all possible, we try to use once daily medications, but many of those 40 plus medications that I listed on the previous slides, many of those require you to take them twice and sometimes even three times per day. Those are not maybe the best options because it can get very difficult. And then just trying to take any medication every day can be a challenge. I know that I only have to take one pill, and if I don't set it out with my toothbrush, I cannot remember 5 minutes later if I've taken it or not. So this can be challenging. Having a pill box can really help people remember and look back to see what they've taken or not taken. Cost. Many of these medications are generic, and so can be available at a lower cost. But if you're having to take many medications and have a high other medical costs, even adding a little bit of monthly costs can be a challenge. Pharmacy access can be an issue. If there's no pharmacy available nearby, if it's the hours don't fit your schedule, this can be a challenge. Poor communication between clinician and patient. I think this is an important one. Um, if the patient with hypertension doesn't understand, well, what are the risks and why are we even trying to lower blood pressure, then they may not be that interested in lowering it, especially if they start to feel side effects. Um, if there's not communication about what are the next steps if this medication doesn't work, what do we do if you feel side effects? What do we do if blood pressure is not controlled? All of these things can help strengthen that relationship and that team approach to lowering blood pressure. Sometimes there are people who have quite large swings in blood pressure. Both they can be very high and they can be very low. And so that can be a very big challenge in terms of what medications to use and when. And then just in general, there are a lot of demands on our attention. And so sometimes, again, an asymptomatic problem like hypertension can get pushed into the background and ignored for a time. And that's a real issue. But I think that um, with the appropriate partnership, not only with your medical team, but also with friends and family and having a good support system, blood pressure is controllable. And it's really important because, as I showed, it's so common and it's so impactful in so many diseases. And we have so much room for improvement on getting the number of people controlled that it's something we cannot ignore. So to wrap up, I'll say with patience, perseverance, and the right partnership, I believe that you can control blood pressure. Um, and it just takes the right team. So in conclusion, in this talk, we defined what hypertension is. We talked about why blood pressure is important because of how common it is and how it impacts so many different cardiovascular diseases. We learned about risk factors for hypertension. So we discussed factors that are difficult to modify or impossible to modify, but also many that are modifiable. We talked about how to accurately measure blood pressure, both at home and in the office. We learned how to lower blood pressure through lifestyle modifications and discussed the medications that can be used to lower blood pressure. And we talked a little bit about why blood pressure can be so difficult to control. But hopefully with that information, you now can feel empowered to take control of your blood pressure. And with that, I will conclude and take any questions that you might have.
Okay, thank you so much for that. You can turn off your share screen. Maybe that's a good thing to do. There we go. All right, so we do have a few questions here. Let me just, and as a reminder, you all, if you could please put them in the Q&A and I will get to them. You're getting lots of great comments, really thorough, great information. Somebody mentioned, and I think you spoke about it as well, the whole white coat syndrome. And, that's a real thing, right?
Yeah, no, that's great. I can go into a little more detail about that.
Yeah.
So, white coat syndrome is when your blood pressure is high when you come into the office, but it's normal outside the office in your regular daily activity. And and this is a common phenomenon. And what it can lead to is if you respond to the blood pressures in clinic and start medications, the risk is that you'll have too low blood pressures in the rest of your normal life. And so that's why I really emphasize to my patients and hopefully in this talk that out of the office at home blood pressures are super important for both diagnosis and treatment of hypertension. Um, Ideally, we have a method of measuring at home blood pressures. It's called a 24-hour ambulatory blood pressure monitor. So this is a device that you wear for 24 hours. It goes off every 30 minutes to an hour, and it collects blood pressures throughout the day. As you might imagine, it can be a little inconvenient to do, and it
Is
is
it a
not.
cuff? Is it a cuff?
It's a cuff.
Uh,
Yep, yep. So
yeah,
you wear it 24 hours straight.
yeah, yeah.
But insurance also doesn't cover it routinely. So what most of us do is ask for patients to monitor their own blood pressures at home with one of those cuffs that I went over that you could find on those websites. So very important to get at home blood pressure.
And along those lines, I'm just curious. I know you mentioned how important it is to have a cuff, but what about some of the wrist devices?
Yeah. So
I
on
kind
those
of don't know.
websites of those validated
Yeah.
devices, there are some options for wrist
Uh-huh.
cuffs. Um, they're fewer than the upper arm.
Hmm.
There are more options that are validated for the upper arm, and that's what we would more typically like to see or like to use. Um, what I would say that for sure the cuffless option. So there's different ones that you put on your fingers or um, that are not. Yeah, right. Yeah, maybe you touch two sensors. Those are not recommended, and those are have not been shown to be validated.
Hmm. But the wrist ones are fairly decent. You think,
Some,
especially
not as
for
many,
travel. Yeah.
but if it's on that website, then they've showed to be uh,
I
to have some accuracy.
Oh, got it. Okay, good to know because those are nice to travel with if you all right, let's see. Okay, here's kind of a more specific question. Can you give some information related to left atrial function and higher pressures and its relationship to AFib, both onset and treatments?
Yeah, sure. Um, So left atrial function, this is something that is can be measured with echocardiogram or MRI. It's not done routinely in the clinical setting right now. So it's mostly in the research realm, but certain measurements of left atrial function have been associated with a higher risk for things like atrial fibrillation, heart failure, dementia. And we have shown with our research group that exposure to high blood pressure over time is related to worse left atrial function. So it might be kind of the bridge between um, high blood pressure, left atrial function, and atrial fibrillation in this example.
Okay, thank you for that. How, okay, how to control nocturnal BP spikes?
Yeah, so
Yeah.
um, normally, what you would see with blood pressure at night is that it would go down by about 10%. That's called dipping, and that's a normal phenomenon. But with some people, it either does not go down or it goes up, especially because at night you're lying down. And so blood pressure in your arm or where you typically measure it, your gravity is there's less gravity pulling the blood down towards your lower extremity, so blood pressure can go up. And so sometimes we have to change the timing of medications where you might give medication before bed rather than in the morning to help lower blood pressure when it's the highest.
Okay, thank you for that. Circling back to the 24-hour blood pressure test that you just spoke of.
Mhm.
There's a website as part of that folks
There's a
can check
website
out?
for blood pressure cuffs that you can buy
Right.
and use at home. So the 24-hour one, that's a specific one that we would prescribe and take back and get the recordings off of. But for most people, having a validated blood pressure cuff that they can keep and then use, throughout their treatment, it can be very helpful. And the website for that is
Mm.
validatebp.org.
Or stridebp.org. I think you mentioned
That's
both.
another one,
They're
correct.
both good. Okay. Hey, and I'm curious, right arm or left arm? Where should we be taking our pressure?
So the recommendation is initially you do both and make sure that they're um, within that they're close to one another.
Okay.
If they are different, then we would follow the higher blood pressure. So if one arm is much higher than the other, that is the number that we would use to titrate our treatment.
And then just routinely stick to that arm um,
Yes.
as you're medicated. Okay. Good to know. Good to know.
But if they're found to be similar, then you could use whichever one is most convenient.
I see. Okay. Where can I read up on left ventricle function research? I believe that's what Deborah's speaking about.
Um,
LV function research. Yeah.
yeah. It's hard. I guess there's so much. So, you know, when we search for articles, we use PubMed, as our um, kind of database for peer-reviewed manuscripts on different research. Um, but there's a lot out there, so it can be a little bit to sift through. It might be if you have a more specific um, more specific question, let's say you want to know specifically about dementia, then you start to put those specific keywords into PubMed or ask your um, ask your care team. They have a lot of resources that can help narrow your search a little bit to find something that can be useful and accurate because there's a lot of misinformation about health in all over the internet.
Yeah. Yeah. Can you speak a little bit about how poor sleep affects our blood pressure?
Yeah, so sleep apnea specifically increases blood pressure, and it has to do with when you have sleep apnea, you have obstructed airflow, your oxygen goes down, and that can lead to elevated blood pressure. So a lot has to do with the low oxygen levels that happen with sleep apnea. But in general, poor sleep in general can lead to higher stress and chronic fatigue, which can raise blood pressure as well.
Yeah. Okay. Let's see. Okay. Anne wants to know if it's normal to have an increase in blood pressure or no, is it normal to have an increase in blood pressure medications as we age?
Certainly, yes.
Uh-huh.
As we saw in one of those early graphs, hypertension or high blood pressure becomes much more common as you get older. So that once you're above the age 70, almost three-fourths of people have a diagnosis of hypertension. And
Right.
those who are diagnosed early, blood pressure tends to rise over time for them.
Okay. Um, and Brian is curious to know what is it about salt that is, so bad for our blood pressure?
Yeah. There's a few mechanisms. A simple one is just that Um, sodium retains fluid, so fluid follows sodium. So if you have a higher consumption of sodium chloride and salt, then water will kind of follow that, and you'll have a higher blood volume in your blood vessels. And like any enclosed tube, the more volume you pump into that tube, the higher the pressure inside the tube. So that's one simple one. Then there's a much more complex mechanism where sodium affects how the kidneys filter the blood and how the kidneys regulate hormones that impact blood pressure. So they have specific effects on that function as well.
I see. And is it possible to be on too many blood pressure medications? One of our folks are asking, it looks like he's on 4 different meds. Is it possible to be on too many?
So I think the goal is to have controlled blood pressure. And so however you get to that is the right way to get to that.
Mm.
So if it's through lifestyle modifications, great. If it's from one medication you get to go, great. If he takes four, but you're in the right zone of blood pressure the majority of time, that's what you might need. So I think it's just a matter of can you control it and how can you control it?
All righty, let's see. Resistant blood pressure, how to resolve.
Yeah, so there's a type of hypertension called resistant hypertension, and the definition has to do with the number of medications that you're on and still being uncontrolled, and you have to have certain medications from certain classes. Um, when someone has resistant hypertension, then Sometimes we do a little extra workup to see is there another cause of high blood pressure, like the kidney hormones are out of sync, or there's a problem with blood flow to the kidneys. Some of these other causes can increase blood pressure. And if you find something, let's say that these kidney hormones are out of balance, then specifically addressing kidney hormones either through medications or through other procedures that can lower blood pressure for people who have resistant hypertension. So it is a category that usually prompts a little bit more investigation.
Okay. And I think you touched on this briefly. Hypertension can be genetic, correct?
Yeah, certainly. Yeah, it tends to run in families. There's no, there's not a specific gene that we would check routinely to find out if you're at risk. But if it tends to run in your family and all of your family members have hypertension, it's very likely that your risk is higher.
Okay. And Wanda has a great question. I'm curious about this as well. Did the recommendations just change recently on the limits for a healthy blood pressure?
Oh, no, they changed somewhere around like 2017 or something, where there was a where they called um where they changed from 140 to 130. So it used to be that 140 was kind of the cutoff, and now we we say we'd like people to be less than 130 when they're treated. There is that gray zone of 120 to 130 that's called elevated blood pressure. Um, that has been called different things in different guidelines, but it has always kind of been flagged as not quite the normal. And that's been that way for a while. But it was, yeah, maybe it was an iteration before, sometime before 2020, I believe, where they shifted from 140 to 130 as that treatment goal.
Hmm. All right. Is it a given if you have chronic kidney disease that you will also have hypertension issues?
That's a good question. Not necessarily, but much more likely that you're going to have higher blood pressures.
Okay. Righty. What are your feelings on some of these smartwatches that they say they're effective for tracking blood pressure, but still are not allowed in the US market? Looks like somebody was traveling and saw some, I think in Hawaii, and then saw some in Spain.
Hmm.
Do you have any
Yeah.
thoughts on those, and do you think they'll hit our market soon?
Yeah, so there's there hasn't been enough data to show that they're accurate. So whether or not they're available, uh, they may be available for purchase, but they're not accurate enough to base diagnosis and treatment plans on.
Okay. Um, this kind of goes back to sort of what I was asking in terms of which arm is sort of more accurate for taking your blood pressure. Craig is wondering, does high blood pressure affect the left side of the heart more than the right?
That's a good question. So when we measure blood pressure, what we've been talking about this whole time is blood pressure in the arteries. Okay, so the arteries receive blood from the left ventricle. It pumps blood out through the aorta and then into all the branches of the arterial system. So that is arterial blood pressure we've been talking about. So when blood pressure is high in the arteries, or systemic blood pressure is another way to say that, then that pressure gets reflected back to the left ventricle or the left side of the heart. And that heart is a muscle. So, like any muscle that is working against a weight, that muscle can thicken. Okay. There, you also have a right side of the heart. Okay. The right side or the right ventricle pumps blood into the lung arteries, the pulmonary arteries. That sends blood to the lungs to get oxygenated. You can also have high pressures in the pulmonary arteries and the lung arteries. That's different. That's pulmonary hypertension, and that's not measured with any cuffs. you can get some idea on imaging, but the true or the final way to diagnose that is with an invasive procedure called a right heart catheterization. So that's a completely separate set of diagnoses and a completely separate set of investigation and treatment. Yeah, good question.
That's interesting. Looks like we have just one more question. Again, if you all feel like you have additional questions, please feel free to put them in the Q&A. Okay, if a person had an allergy, a hive, they had hives to monopril, can they take another ACE inhibitor? Also, if they had a reaction to Norvasc, swollen feet, can they take another calcium channel blocker?
Okay, so we'll take the first one. So with an allergic reaction to one class, so when I say allergic, I mean like your body has actually mobilizes cells um, to confront this medication, and hives is one example of that. Then we do not use any other medications in that class because it's most likely that your body will react in the same way to that class of medications. So no to the first one. For the second one, where you have swelling in your legs, that is actually a function of the medication. So that medication works by relaxing the muscles around your blood vessels and causing them to dilate. And so it decreases the pressure inside of the vessel because it gives a little bit more space. But when that happens, blood can pool wherever gravity is the greatest. And so when you're standing, that's in your feet. And so blood can pool in your feet, and then it can kind of leak out of your blood vessels, so to speak, and cause some swelling. That is that is a function of how that medication works, and so isn't necessarily a it's not an allergic reaction. It's not necessarily a dangerous reaction. It's more, functional and annoying, and sometimes can be painful. So you might react differently to a different calcium channel blocker. You might react differently if you take it at a different time or a lower dose. So there are other things certainly that you can try, and don't have to exclude a whole class of medications for um, swelling in the feet.
So I'm curious, just kind of adding on to that, how as a patient, how long do we give a medication to sort of level out? Like if we take it for the first few days and we notice that swelling, uh,
Yeah.
do we give it more time or does it depend or
Yeah. If it's And so this is where that patient provider communication is so important because some reactions are dangerous and important and you need to stop right away. Like an allergic reaction, your face is swelling, you need to stop immediately. If it is a little bit of lightheadedness or swelling in your feet, but you otherwise feel okay, that's something you might, wait for a week or two and see if you adjust to the medication and feel well and can go forward. So that's where the communication piece is so important, because a lot of times you can just give it a little bit of time, but there are important exceptions that need to be recognized immediately.
okay, thank you. Can a person have a severe heart attack without having high blood pressure?
Yes, yeah, isn't it? So blood pressure is not the only risk factor for heart disease, but it is a very important one, and because it's so common, it's so impactful. But no, certainly you can have heart disease, you can have heart attacks with normal blood pressures.
Somebody's asking about substitutes for salt. There's some of those seasonings you can buy in the grocery store. Are there
Yeah.
any drawbacks or concerns about salt substitutes for those of us that are cardiac patients?
In general, no. In general, they're quite good. And if you're someone who is has particular limitations, like if your potassium is very high, and so using a potassium salt supplement might be a problem. That's something you should talk with your doctor about. But in general, the salt substitutes are very healthy, very safe.
Okay, I think we just have one final question. Let me just double check over here as well. Lots of great information. People were curious about the website, so I did put those websites in the chat, so you all
Perfect.
take a look at those. I think a final question. Ron is wondering, is it normal for your blood pressure to be higher in the morning upon waking? And then he goes on to say that he feels warmer an hour after waking up. Is there a
Yeah.
correlation there?
So yes, the blood pressures can spike in the morning. That's known. It has to do with cortisol release, one of the factors. You have a spike in cortisol in the morning, and that can increase your blood pressure, and then it can come back down. If you're taking blood pressure medications, then certainly there are different times of day where your blood pressure can be high based on the metabolism of those medications when they're at their peak, if there's overlapping, medications. Um, but in general, most people have an AM spike in their blood pressure, yes. And then in terms of feeling warm, I don't know if those two are correlated or not. Again, that maybe could be related to different medications
Mm,
um, or something completely unrelated.
okay. All right, let's see. We've already got that one and this one. I think that might be everything. Let me just look over here. I think that's it. Anybody else have any other questions or concerns? Well, I know I have certainly learned a lot tonight. I appreciate your time. It's interesting. I think those of us that have been cardiac patients for an extended amount of time, sometimes we do um, not feel like we know it all, but it's important for us to kind of hear the materials all over again. And there are advances too. So hang on a second. Another question, sorry. In reference to the morning spike, let's see, where did it go? Uh, okay. Do you ignore the morning spike number if your pressure tends to be normal otherwise?
Um, so usually you look at the average blood pressure for the day, and so if on average it looks okay, then that is what you would go by typically. So I'll use the 24-hour blood pressure monitor as an example. We get an average for the entire 24 hours, and then we get an average for the daytime values and the nighttime values. And those averages are what the treatment is based on usually.
Okay. We do have some last minute questions. Does blood pressure medication affect your heart rate?
Some do, yes. So those classes of beta blockers, those slow down the heart rate. And then there is a certain subclass of calcium channel blockers that can also slow down the heart rate.
All right. I have one more question.
Sure.
What's on the horizon for us as heart patients in terms of blood pressure medication? Anything new and exciting, sort of that
Yeah,
we should be looking out for in the future?
yeah. So one intervention that's been approved by the FDA is called renal nerve denervation. So this has to do with the nerves coming in and out of the kidneys, and the kidneys are so impactful on monitoring and regulating your blood pressure. So this is something that's already approved. It's already being done, and can be an option for the right patient population. And then there are other medications that are under investigation that work. The way that they work is by blocking the formation of a certain protein or hormone that can last for a very long time. So there are certain medications that you may only need to take a couple of times a year
Mm,
instead of every day or twice a day. So I think those are exciting things that might be coming, which can really address this issue of, boy, it's really hard to take this medication every single day. So we'll see.
Interesting. And what can you repeat the name of that medication? The new innovative medication?
So renal nerve denervation is the procedure. And then let's see. Oh, what's the name? I think the medication, I might have to get back to you. Is that okay? I don't want to
Great.
misspeak.
Yep. Yeah, I see who the question is
Okay.
coming from. So Sam will get back to you. Um, all right. I think that's it. Thank you so much. I know, again, as I was mentioning, I've learned a lot. It's always a great reminder. I know that there are some of us here in the chat and in attendance tonight that have been heart patients for quite a while. So it's good for us to to kind of be reminded of, conditions that we need to pay attention to. So we appreciate your time. Thank you. And thank you everyone for attending. Have a beautiful night and good health to everyone.
Yeah, thanks for having me and thanks for all the great questions.
Good night.